I have no particular disclosures to make for this topic, although I am an investigator and or consultant for many industrial companies. This is most likely the most important slide that I can show you. It says a proper diagnosis starts with a proper examination of your patients. Unfortunately, it's an open door that is still needed to be addressed, because many of us make this mistake that we, by picking up the phone or by just looking at our patient's face, try to find out and think we know what they have and try to prescribe some treatment and send them home. And I think in modern times, this is not an appropriate way to do. So let's start with, I have 5 little items for you. Let's start with first item, which is the symptomatic infections. This is the more clear and everything issue. If you talk about Candida, most people will have an itch. It causes typical signs, and if there is no itch, the chances that this is Candida is much less. The fishy smell that you all know is typical for bacterial vaginosis. Not all women with bacterial vaginosis have this smell, but if you have it, you can be pretty sure that bacterial vaginosis is there. Aerobic vaginitis is marked by soreness. It gives a sore pain, while cytolytic vaginosis, these patients complain more of burning. And then trichomonas, as you know, it has more a purulent, yellowish, foul-smelling discharge. So coming back to BV, we have this fishy smell. We can measure the pH, which will be high. But what most typically is the case, if you look in the microscope, we see these typical cells that are covered by a granular flora, which we call a clue cell, because this gives you the clue to the diagnosis. For Candida, it is very often a clinical diagnosis, but you have to look. So what you would typically see is this edema of the labia. You see the redness of the labia. You see the lichenoid changes, sometimes because of scratching. You see the typical fissures there. This is a fissure at 12 o'clock. You see the satellite lesions there in the bottom. Also, you can have typical lesions here at 6 o'clock or perianally even. Inside the vagina, you see this curdy-like, as they call it, the cottage cheese type of discharge. It's not always the case, but if you do see it, it's rather typical. Sometimes, if this is not enough, you need to make a firm diagnosis and you bring it to the lab. You can use a swab for this. It will be cultured on a regular medium with blood agar, or on a specific medium with chrome agar, which also enables you to tell you if it is an albicans or not albicans. But what is most crucial for me is, instead of sending swabs to a lab and waiting 2 days for a result, have your patients either suffer from these symptoms or give them some treatment without you knowing for sure that the diagnosis is right. You can certainly ascertain the diagnosis by using at your office this type of microscope. So we usually use a 40 magnification with a phase contrast lens, and this will tell you very elegantly, as you see in this picture here, a hyphae. You see a small blastospore here underneath and a small arrow, which is typical for Candida. If you see this, you don't need to send anything to the lab. This is a certain diagnosis. Nobody can doubt this patient is suffering from symptomatic Candida. But also it allows you to see much more. Here you have a typical image of BV, as we discussed before. Here you have a typical Trichomonas case. Here at the big arrows, you see a Trichomonas parasite. You see lots of leukocytes that are very toxic, causing an inflammation in this patient. And also what you can pick up easily is the diagnosis of AV, which we will address in a couple of minutes in more detail. So this is a typical image that you easily pick up with your microscope. So not only the microscope will tell you if this is Candida, also it will tell you if it is anything else. So this is a very valuable tool. How does that work, this microscope? Well, first of all, you look at the lactobacillary grades. You have a lactobacillary grade 1 if it is full of lactobacilli, no other bacteria there. The other side of the scale is lactobacillary grade 3. This means there is no more lactobacilli. It's all taken over by other lactobacilli, as I gave you these two examples before. And 2A and 2B are two intermediate steps. 2A being more lactobacilli than other bacteria. 2B being the opposite, more other bacteria than lactobacilli. Once you've done that, you know to look, you can look to pathogens. Go step by step. First, you look lactobacilli, then you look pathogens. They can be anaerobic or granular, as I showed you in nature. They can show you the Mobiluncus morphotypes. These are small comma-shaped bacteria that are moving all the time. And if you go for the Eisen criteria, you can also see the cocci, sometimes in the form of chains that are present and point to another condition than BV. You can see Leptotrix, Actinomyces, you can see Trichomonas, and you can see all different forms and types of Candida. So these are the pathogens to look for. Number 3, you look at the leukocytes, and this is very, very powerful in microscopy. You don't have this information if you send something to the lab. You can also have information on the leukocytes. The leukocytes, you see how many they are, what the proportional number per epithelial cell is. You see how toxic they look like. I will show you examples of that because it tells you what it can be. Furthermore, you have the opportunity to look at the epithelial cells. You can see if there is parabasal cells, which tell you the maturation index will be low. And you can see on the other spectrum, if there is cytolytic cells, that means the cells are being damaged by high acidity. Finally, you look number 5 for background artifacts. You look for cream, you look for dust, you look for sperm, you look for blood, you look for many other items that can be there and disturb your diagnostic possibilities. Here you see an image with no lactobacilli. You see this bunch of leukocytes, but you also see they're very swollen, they're very, very round. They have these dots inside, which are lysozymes. This is how it looks like after hydration of a dried specimen, but you can still easily pick them up. This is the epithelial cells. If you look at superficial cells, they have very edgy, large cytoplasm, small cell nucleus. Here the nucleus gets more bigger, the cell cytoplasm are more dark, and the edges of the cells less in edgy form, so it's more rounded. And then the parabasal cells, you see large nuclei, very dark cytoplasma, round cells. So these are very immature cells. This is a very important marker to look at. So the number 3 you should look at is the less well-known infections. So we know all bacterial vaginosis and Candida very well, but here you have aerobic vaginitis, cytolytic vaginosis. What to think about these? Well, we already discussed many of these items. These are the lactobacilli grades. These are the number of leukocytes per epithelial cell. You can count them. You can see if there is any toxic leukocytes present and how what a proportion of them has this feature. And then finally, you look in the background, what type of bacteria are there. So if you take these 5 criteria together, you can make up the AV or the aerobic vaginitis score. So you do need a microscope for this. So if you look at the AV score, it should be normal if you have lots of lactose, no signs of AV. Light if you have a score of 3 to 4, moderate if you have a score of 5 to 6, and the severe AV has a score above 6. So the severe AV, it's basically the same as desquamative inflammatory vaginitis. It's an entity that was already diagnosed or known by dermatologists in the past. Normally, the most severe cases of AV, we call moderate severe AV, are the ones that are dangerous, for instance, in pregnancy and should be treated for. is this something that you should look at? Here you see the value of the pH that we studied in Ugandan women. So everybody tells you that in Uganda and in Africa, people have lots of BV. And indeed, if you look at BV, up to 30%, 34% have BV in the group of patients with a pH above 4.7. So there is lots of BV in these women, but all of them do not have BV, but lots of them also have AV, as you can see. So the AV, moderate severe AV, is 17% in these women. So if you never look, you don't see it and you don't know. So just by saying that an abnormal flora with an abnormal pH in African women, 1/3 of this abnormality is not BV, it's AV. Is this frequent all over the world? Here you see in different cultures in the world, you have a prevalence of 7 to 15% AV, and in pregnant women, it's a little less, but it's still quite prevalent. Very remarkably, in Northern Americas, Canada and US, no data are available. It seems that they seem to ignore this condition. They don't want to study it, but it's their problem. So then there is people that say, listen, look at the BV together with inflammatory response, and they say it shows a severity with cervical neoplasia with abnormal pap smears. If you look carefully though, if you look at the abnormality of pap smears, here you have any pap smear which has alcyl or more, you see that BV is no longer correlated with these abnormality in pap smears if you at the same time also look at AV. It's actually AV that causes this association. If you look at it together with BV, you see BV is no longer the cause. So again, if you don't look, you don't find. You need to use your microscope. And this was confirmed in a bigger study published in Portugal in the European Journal. AV is also associated with severity of painful sexual intercourse. Here you have the vulvodynia patients, and you see that with bifocal disease, that means at 5 and 7 o'clock, if you look at the Q-tip pain score, if it is more than 6, you see clearly that most patients have a very high number of AV abnormalities, but not BV. And also, if you look at the focal disease with also pain at 1 and 11 o'clock, you see that almost 40% of patients have a severe AV in their smear. So it is something that is necessary. If you look at patients with painful intercourse, you need to use your microscope to rule out these conditions. Finally, in pregnancy, here we showed that abnormal vaginal flora, which is no lactobacilli present, is correlated with preterm birth much more than the normal women on the left side, and having more preterm birth before 24 weeks, before 34 weeks, and before 37 weeks. And you see also for AV, the cockroach type of AV has similar associations with preterm birth, which is not the case for full-blown BV, as you could see. This is a completely different picture. This is lots of bacteria, normal, healthy-looking lactobacilli. You see the nuclei here of the cells that are being damaged. You see here the cytoplasma next adjacent to this. So this is cytolytic vaginosis. It's very strong lactobacilli. It's not a real infection. It's not a vaginitis. It's the high acidity caused by these lactobacilli that causes this disease. And it's very typical that it causes burning. So the treatment is to lower the acidification of this vagina. These people are not benefited from any type of antibiotics or antimicrotics. And it does not make any sense to send something to the lab because you will get back a Group B strep or an E. coli. You will start treating with antibiotics and you will screw up this patient's life. So it's not a good thing to do. You have to diagnose this yourself. Number 4 of my things I want to discuss with you is the mixed infections. So the microscope will allow you to see before your patient leaves the office. that in case this patient, you see here a very nice bunch of Candida items. These are blastospores with little buds, which is budding blastospores. But at the same time, you see very clearly in the flora here, this is a completely disrupted flora with BV, anaerobic flora. So this is AV and BV at the same time. Excuse me, Candida and BV at the same time. Here you have Candida blastospores, and there is a pseudohyphae. So this blastospore is going to sprout. So this is the beginning of a mycelium. And you see some lactose, but you see lots of other bacteria. So this is a lactobacillus grade 2B together with Candida. Here you see lactobacillus grade 1 with a very nice Candida. So you can see these mixed infections very easily. Again, here you have this very nice hyphae, Candida hyphae, together with a full-blown BV at the same time, the same patient. So if you give this patient metronidazole because of a smell, she will definitely come back with a severe itch, and she will tell you, you are a lousy doctor because you gave me more symptoms than I had when I came to you. So you have to pick this up from the beginning, and this makes you a good doctor. Then there is these forgotten infections. This is this chlamydia, this trichomonas, I'm sorry. So we all think trichomonas is no longer amongst the people. What we studied in Belgium with 60,000 pap smears. We all tested them with PCR for TB, and what you could see is a 0.4% prevalence of Trichomonas vaginalis in Belgian women. You say this is not much. I say this is huge. I mean, this is 1 in every 250 patients that presents for a pap smear also has Trichomonas. So it's a lot. If you look at the epidemiology, we learn something more. This is HPV epidemiology. In these samples, we see a peak between 20 and 26 years of age, which is expected. Then it goes down over time. But with Trichomonas, it was a very strange finding that there was a small peak at the same age group, but the biggest peak is here seen at 40 to 45 years of age, which is very typical. And we could find that if we looked at the origin of the patients, that this peak was caused by people bringing in Trichomonas from abroad, from foreign countries. So these were people moving into Belgium without being screened for Trichomonas. Finally, we have to discuss recurrent infections, and this is a very important subject, and we will give you some information on this, not only about the diagnostic items, but also the treatment. So if you have recurrent infections, we have to talk about BV. BV recurs in more than 50% of the women within 1 year time. Long-term probiotics can be of help in these women. But there is not many new drugs around, so we will still suffer to keep these patients well. Aerobic vaginitis is a therapy-resistant, long-lasting pain in the ass for many women, and it causes discharge, so it requires long-term therapy. We come back to that in a minute. Candida, be aware of non-albicans Candida and of the increasing rate of Candida albicans resistant, which is also appearing nowadays. And for Trichomonas, be aware that some of these trichos are having resistant parasites that don't get properly treated with metronidazole. So you have to do a test of cure to see if these patients are cured, and you have the treatment of the partners as well. So having said this, in summary, you have situations where the pH is normal, low, or high. And if you fill in the items, you will see that normal is there in the middle, while BV, TV, and AV, so the aerobic vaginitis, bacterial vaginosis, and Trichomonas vaginitis are on the side where the pH is normally high. On the other hand, where the pH gets very low, less than 3.8, you have to think about cytolytic vaginosis. So pH measurement helps. Candida, however, can situate itself amongst all of these conditions, and it can coincide with normal flora, with cytolytic vaginosis, with BV, AV, TV, and everything. So then it comes to symptoms. The smell is linked to the lower part of the panel. The pain points more to AV, the itch more to Candida, and the burning more to cytolytic vaginosis. So if you have this scheme in mind, you will be able to tell in your clinic much more in which direction this will go. So when and how to treat was the question. Well, in general, don't treat cultures. If you treat something, send something to the lab, you get back a culture, it doesn't fit with the symptoms of your patients, don't treat. Treat symptomatic patients only. Vaginal dysbiosis, which can be AV, BV, or trichomonas in pregnancy. Also, this pregnancy-linked complications are seen. So you have more preterm labor, you have to screen and prevent, even if no symptoms. So in this pregnancy-related abnormalities, you have to try and prevent. Sexually transmitted infections, please be aware that there should be a low screening threshold. Always treat partners, always consider a test of cure, and be aware of other STIs. For the recurrent vulvovaginitis, please consider maintenance treatment. This holds as well for Candida as for BV as for AV. So just to come back to one of these conditions, which is now trichomonas, we did a large study in Flanders together with the Flemish Society of Gynecology and a lab in Antwerp and the university. And we tested 74,000 pap smears also for trichomonas. Patients did not have to pay for this. We found 2,790 positive, 718 of them were second time positive. So they had 2 positive PCRs when they had a subsequent pap smear. So we were interested to see what happened. I mean, why would a patient with trichomonas come back for a next pap smear and still be positive? So we sent them questionnaires. We got back valid questionnaires, 640 patients, of which was 45%. So of these answers, very strikingly, we could see that patients would say in 38%, they would say, we indeed saw this result. We treated with proper medication for trichomonas. 17% of doctors said, this is not important, this finding. We did not give treatment. 6% said, we don't believe these results. You have to repeat the treatment. They send a swab to the lab, got back negative results because they send a regular swab, which is of course negative for trichomonas. And then 31% have not even seen the results. So this was very striking to see that around 60% of our patients were not treated properly by the doctors sent in pap smears for treatment. Concerning AV, how is this being treated? I give you this slide because otherwise you will ask it anyway. Well, Candida AV is split up in a infectious component, an atrophic component, and an inflammatory component. And depending on which component or components are present when you look in the microscope, you start treatment accordingly. So if there is a purely infectious predominance, you would consider to use local antibiotics or maybe an antifungal. If there is more atrophy present, you would use a local probiotic with estriol or local estrogens. If there is a inflammation present, you would consider to use local corticosteroids. So you compose a cream based on these 3 items and see what patients benefits most. And then you, of course, do proper follow-up. So is there anything new in treatment? So the maintenance treatment metronidazole for BV doesn't cause any long-term efficacy. You can give it for some time, but after 6 months, you will see the prevalence of BV is still the same and the recurrences come back. If you use vaginal probiotics, you can ensure a long-term maintenance therapy, and this helps many of these women. It's not sure what oral probiotics do. There is still studies ongoing. New drugs are coming. Bacterial endolysins are coming. They're very promising, and it distracts the biofilm. This is something to look forward to. Also, you should consider these cases condom use, as most BV is enhanced or transmitted through sexual activity. Treatment of BV in pregnancy with antibiotics does not seem to alleviate the risk of preterm birth. So we need better treatment for that. And as we speak, we're currently doing a study with probiotics instead of antibiotics for these conditions. So finally, let's look at recurrent candida. Is this frequent? Well, 7% in European figures of women show at least 3 to 4 episodes per year. And this is mainly seen in the age group of 24 to 34 years. So what to do with them? We give them, we consider this now a chronic recurrent disease. So we give them maintenance therapy. We don't like to give one type of therapy, then the other type, jump to another type. We want now long-term therapy for a chronic disease. So what we do in Europe, most of the time, we give a decreasing dose maintenance of fluconazole, first weekly, then 2 weekly, then monthly, but not without at times checking if you can decrease the dose, because you need negative clinical findings, you need negative microscopy, and you need negative culture results. And only if these conditions are met, you can decrease the dose from once weekly to once every fortnight to once monthly, and so slowly try to stop the regimen. What we did see, however, in this regimen is that over time, you see more non-albicans candida in these recurrences. So if we look with PCR, and this is a group from Estonia, and I think Kai will like this, that I show this. We did a study together to microbiome analysis, and what you would see with that, on top of all the bacteria, is Candida albicans, of course, prominently being present in these women, but also lots of uncultured and unknown Candida albicans strains. So we have lots to learn. It's not only what we can culture in the lab, there will probably in the future be detected much more other fungi there that we didn't know existed. The problem is that there is an increasing risk of Candida resistance against fluconazole, Candida albicans resistant besides this. So what are the new treatment options? Because we need them. We have more non-albicans, we have more albicans resistance, so what to do? These are the options we have. We can enhance the azoles we use. We can have new generation azoles that we use. We can develop non-azole treatment drugs. We can try and use probiotics. We can try and develop vaccines. Here I show you briefly what the lactobacillary probiotics can do. You see here that if you treat women with probiotics instead of antifungal disease, the ones that need antifungals increase up to a certain level, and here after 20 days you see that only half of the patients has used antifungal drugs, and the other ones were much better with probiotics. And you see also here that the symptoms and everything goes down with probiotics alone. Another study here, if you give adjacent to fluconazole probiotics, you also see that the prevalence of Candida by culture method is much lower in the group that used the lactobacilli instead of placebo. If you see that at a short term, you see some effect here in multiple review studies, but in the long term, you couldn't see any difference yet. So there is still work to be done. This is an enhanced azole study where they used either decolinium chloride or domified bromide together with miconazole, and you could see a much more lethal effect on the Candida albicans strains. So there is a lot to be expected from an additional drug to be used together with miconazole in a cream. This is a non-albicans, a non-azole study that was shown recently. It breaks out from Gilbert, and you could see there were dose finding with different doses versus a control group with only fluconazole. You could see there is very elegant data on the long term, maybe even a little bit better than fluconazole alone. The only problem is there is still lots of side effects. Half of the patients had gastro and intestinal side effects. Another, and that's my last slides, Mr. Chairman. Another study is a very exciting one, the 1161 product now named oteseconazole, used in women with recurrent episodes of Candida. You see over time that the recurrence rate of Candida in these women in one study, CEL11, brought by a tremendous reduction of the number of recurrences. And this is with a follow-up of 1 year, of which only the first 12 weeks were treated. So you treat for 12 weeks weekly, and then you follow up for a year, and you see this kind of reduction of the recurrence rates. And the same was seen in another study done here in Europe, where I participated in. Only 3.9% recurrences versus 39% in the group that received placebo after the stopping of the induction treatment. So this is tremendously good results. And also, if you look at the side effects of this new drug, no signals of any kind in these in this new drug compared to placebo. So to conclude, we have a take-home message for every day of the week. First, bacterial vaginosis is easy to diagnose and does not require lab testing. The treatment of recurrent BV has promising futures with arrival of proper probiotics and a new drug like endolysins. Recurrent Candida, for instance, is a chronic illness now. It requires therefore maintenance therapy, especially the recidiv regimen that I showed you is herefore suitable. However, we have emerging Candida albicans resistant and increasing numbers of non-albicans strains. For this reason, we need new azoles, new non-azoles, maybe vaccines and probiotics. But oteseconazole seems to be the most promising product. Finally, trichomonas is not done, treatment is not done properly, and it can be a very nasty, untreatable condition at times. AV is also frequent. It requires office microscopy and permits tailored treatment. So in a nutshell, this was what I wanted to share with you. And if there's any questions after the next lecture, I'll be willing to answer all of them. Thank you for listening.
Thank you very much. Thank you, Professor Gilbert Donders, for this excellent overview. And as said already, please send your questions all to this question and A button, pushing there and writing down your questions. We will take all the questions after the next presentation. So it's my pleasure to hand over moderating job to my good colleague from ESC, to Dr. Ali Kubba from United Kingdom. So thank you.
Okay, thank you very much, Kai, and welcome to our audience. We already have a few questions, so keep the questions coming. And as Kai said, if we don't have time to answer the questions in this webinar, we will answer them in writing and post them on the ESC website. So that's another reason why you should join the ESC. I'm Ali Kubba. I'm the Vice President of the European Society of Conception and Reproductive Health, and I am a gynecologist working in central London at Guy's and St. Thomas's Hospital. And it is my great pleasure to introduce Professor Marc Arbyn, again from Ghent. So he's from the Faculty of Medicine and Health Sciences at the University of Ghent. And he is the head of the unit of cancer epidemiology at the Belgian Cancer Center. And he's a world authority on HPV. And we've asked him to talk about HPV and the cervix, when to test, and what tests to use. So Marc, if you put your, unmute yourself and switch your camera so that we can see you. Excellent. It's over to you, Marc.
Okay, thank you, Professor Kubba. Dear Ali, thanks for the invitation to share my thoughts on HPV testing. HPV screening in the context of cervical cancer screening. I will start my presentation with presenting in a nutshell the evidence on HPV-based cervical cancer screening. Then I come to one of the points of the title of presentation. I will address the question, which HPV tests can we use as screening? Which tests are validated? HPV tests can be used on conventional specimens, cervical specimens collected by a clinician, but they can also be applied on a self-sample. I have a slide to answer the last question. When should we use the HPV test? So first topic, primary screening. What is the evidence that we have today to consider HPV as a more performant screening test? There is strong evidence from randomized trial that HPV screening protects better against future pre-cancer and also future cancer compared to cytology screening. We have first-line evidence from randomized trials which indicate that pre-cancer has a lower incidence among HPV negative women compared to women that are screened in the other arm of the randomized trials and are cytology negative. The relative risk systematically is lower than 1 among HPV negative women. And you see here a summary of the evidence from randomized trials where the outcome is detection of CN3+. We have here a relative risk. It is the incidence, the cumulative incidence after a negative HPV test compared to the incidence of pre-cancer among women that are cytology negative. If there would be not a difference, then also the studies should point here a value of relative risk being unity. But we see that in 7 randomized trials, we see systematically, consistently a lower risk. And if we pool all these studies, we see that the pooled relative risk is 0.39. It means that HPV negative women have a future risk of developing in the coming years a CN3+, which is 61% lower than women with a negative pap smear. We also have data from 4 randomized trials where the outcome is incidence of invasive cervical cancer. And we see here that overall, the pooled value from the 4 randomized trials is 0.21. So a reduction in risk of almost 80% in women that are HPV negative versus women that are cytology negative. Now, in our last edition of the European guidelines published in 2015, we highlight that screening should be done with a validated HPV assay. And I will answer the question, which assay? The interval should be at least 5 years. Women can start screening at the age of 30 to 35 and go on up to the age 60, 65. Before that age, cytology could be offered at intervals of 3 years. Well, these guidelines are now 6 years old. This guideline was an appendix to the previous guideline of 2006. What we need now is a full 3rd edition of European guidelines for prevention of cervical cancer, including not only screening, but also vaccination with guidance on how to integrate both. We need guidelines on how in the future vaccinated cohorts should be screened, and risk-based screening would be an important chapter in future guidelines. Now, that was the evidence about HPV screening. Now, which tests can we use for cervical cancer screening? Well, as I said, from randomized controlled trials, we know that the protection against pre-cancer and also of cancer is higher than with cytology. In all the randomized trials, 2 high-risk HPV DNA tests were used, the hybrid capture 2 assay and the GB56 PCR. Therefore, we consider these 2 tests as the comparator tests. And for other new HPV assays, we do not have to repeat these randomized trials, including 10 years of observation and 100,000 of women to be followed up. We just can look for non-inferior accuracy of a new test compared to these comparator tests. Now, the guidelines for evaluation of new HPV tests have been described by Meyer, published 12 years ago in the International Journal of Cancer. Well, these criteria include, for new HPV tests, in order to accept them for screening, we have to demonstrate non-inferior sensitivity and specificity for an outcome of CN2+. And you see here the statistical thresholds. I do not comment further on that. So besides sensitivity and specificity, also good reproducibility, intra-lab and extra-lab, should be demonstrated, and this should be done on samples that come from a representative screening population. Now we have tried to answer the question, which are now today these tests that fulfill the Meyer guidelines. We have here a forest plot, at left the relative sensitivity, at right the relative specificity. Relative sensitivity means it is the sensitivity of the new assay divided by the sensitivity of the comparator assay. And as I've indicated in a previous slide, we accept two comparator tests, the hybrid capture and the GP-PCR. Now for 1, 2, 3, 4, 5, 6, 7, 8, 9 tests, we see that the relative sensitivity is concentrated on the unity line. So it means that they are at least as sensitive as the comparator tests. And we see the same for the relative specificity. We see that for all these 9 tests, the relative specificity is near unity. So we can conclude from this meta-analysis that these 9 tests are as sensitive and specific as the comparator tests, which were already validated through population-based randomized trials. We have 9 new HPV tests together with the comparator test. We can conclude that today in primary cervical cancer screening, these tests can be used as safe assays in primary cervical cancer screening. And this was published a few months ago in the Journal of Clinical Microbiology Infections 2021. This is now considered as a world standard, also accepted by WHO in the new screening guidelines. Well, the Meyer guidelines only concern HPV DNA tests. There are also tests that can detect the mRNA of the virus. The Meyer guidelines are also valid for the RNA test, but since it is not a DNA test, we need to document in addition that these RNA tests are longitudinally safe. We see here a forest plot, which was similar to the previous forest plot. This is the cross-sectional relative sensitivity at left, relative specificity at right. And we see here for the most important RNA test, the Optima test, that the sensitivity, relative sensitivity compared to the comparator tests, that they are near to unity. We see here the pooled value is 0.97 with a confidence interval that includes unity. So Optima is similarly sensitive compared to the validated comparator tests. When we look at specificity, the pooled value is the relative specificity is 1.03. So the specificity is 3% higher, and this is statistically significant since unity is included from the confidence interval. Now we need also longitudinal performance before we accept mRNA tests in primary screening. And we have today 4 studies that contain longitudinal performance data. We have here a German trial and here a Canadian trial, or the focal trial. And we see here the cumulative risk of CN3+ by time in the German trial up to 7 years. And we see that the risk after negative Optima, it's in purple, is higher than after a negative hybrid capture. So the safety is here a little bit lower. However, when we see at the Canadian trial, which has a follow-up up to more than 10 years, we see that the risk after negative Optima and after a negative hybrid capture is very similar. It's even a bit higher after a negative hybrid capture, but not significantly higher. So we can conclude that on the long run, Optima is as safe as the comparator test hybrid capture. Now, HPV testing is more performant than cytology. It has another advantage. It can also be applied on self-samples. And we have assessed the relative accuracy of HPV testing on self-samples and compared them with the same HPV test on clinician samples. And we observed similar sensitivity and slightly lower specificity of HPV testing on a vaginal self-sample versus a clinician-taken cervical sample if a validated PCR test is used that targets DNA. And I've shown you in the previous slides which tests are clinically validated. Now, another type of tests which is popular in HPV screening or signal amplification assays. And the most known example is the hybrid capture. There we see a lower sensitivity on self-samples. A new finding, but I will not present data on this today, is HPV testing on urine specimen. Now, as I told you in the previous slide, if HPV testing is done with a signal amplification-based test like hybrid capture, we see that the sensitivity on a self-sample, we have here the data in blue, the sensitivity and specificity on self-samples, and we see that the blue points are on average lower than the red points where we have the signal amplification-based test studies applied on a clinician sample. So it was a very significant statistical difference. Sensitivity with hybrid capture is lower on a self-sample compared to on a clinician sample. Now here you have another type of plot. It is a forest plot. At left, the relative sensitivity for outcome CN2+. At right, the relative specificity for CN2+. We have included in the first block studies from a screening setting. In the second block, screening from a follow-up setting. And we have again the relative sensitivity of PCR-based tests on a self-sample compared to on a clinician sample. And here we see both in screening and in follow-up, we see that the relative sensitivity is concentrated around unity. Pooled all studies together, we have a relative sensitivity of 0.99 and unity is included in the confidence interval. So no difference in sensitivity of PCRs on self compared to clinician samples. A similar picture we see for the relative specificity. The relative specificity pooled is again 0.99, but here the confidence interval excludes unity. So there is a small loss in specificity. So all these tests shown in the previous slides were DNA tests. Now, what is the performance of the Aptima RNA test on a self compared to clinician sample? Here we have 5 studies to include, and we see overall pooled a relative sensitivity of 0.84, unities excluded. So Aptima is less sensitive on a self compared to a clinician sample, whereas the relative specificity of Aptima is similar on a self compared to on a clinician sample. Now, we evaluated all these tests according to the Meyer guidelines. The Meyer guidelines are a bit old. We are now reviewing a new generation of guidelines, which will deal with the design, statistical issues, genotyping tests, testing on self samples, questions regarding cutoffs of the test. Now, one of my last slides, is in fact a repetition of the European guidelines already highlighted before. I just repeat, you should not use HPV testing before the age of 30, since HPV infection before that age generally clears and is not associated with lesions. You can continue up to the 60s. The interval should be 5 years or longer. And before the age of 30, we can continue with cervical cytology. Well, to conclude, in primary cervical cancer screening, we can only accept clinically validated HPV tests. We have 11 validated HPV tests, and the PCR systems among them can also be used on self samples. For RNA, yeah, if a clinician collected specimen is used, Aptima is as good and safe as the DNA tests. Since this year we have now longitudinal performance data, but this is only available for a very limited number of studies. And yeah, RNA should not be used on self samples. So, dear Chairman, dear colleagues, I thank you for your attention.
Thank you very much, Marc, for such a clear presentation. And one of the advantages of having Doc Matter as our platform for discussion is that we have had a lot of discussions on screening in Europe, and I think there is still some lack of consensus on that. So it is now my task to thank our 2 speakers, and I don't know whether Peter has the closing slide before we go to the questions. I'm going to also do some summary of what we've heard from our 2 eminent speakers. Do we have the slide, Peter? While we're waiting, I want to again remind you that at the end of May of next year, we should have our Congress in Ghent, and Kai mentioned chocolate. So the other feature of Ghent, apart from the culture, the museums, is beer. So we're going to probably have a chocolate and beer sort of crawl, you know, through pubs and chocolatiers after the dinner we held in Ghent. So I'd encourage you very much to join the society. I want to just pick up some of the things we've learned from our 2 eminent speakers. So Gilbert gave us a really interesting and well illustrated talk, and we now have to think about itch, smell, soreness, and burning. And I think that is a good sort of distinction of the various pathologies that happen in the vagina. I think he's introduced aerobic vaginitis as a concept that we need to start to think about, especially in relation to pregnancy complications. I mean, in my work, I see a lot of, for instance, postnatal patients who are breastfeeding, who I think need estrogen, who I think have an element of aerobic vaginitis with soreness. And I'm now going to start thinking about that. The other point that I think was definitely worthwhile in relation to aerobic vaginitis is think about infection, about atrophy, and about inflammation. So this combination, you know, whether you use an antibiotic, antifungal, estrogen, as well as local steroid. I think the message, do not treat cultures, but treat symptoms, is a very valid message. And I think we have questions about, you know, which tests do we do, and do we need to do tests if we are very sure about the symptoms. And probiotics and the impacts on the microbiome, I think, is also very, very important. And I was thinking that one of the things that, and maybe that's something that Gilbert can talk about, one of the things that we discussed with patients in relation to bacterial vaginosis is whether smoking and oral sex actually increase the risk. And it might be worthwhile just alluding to that, because these are things that we can, in a way, lifestyle issues that we can talk to our patients about. And then we've had the very clear, very important, very timely lecture by Marc on HPV. So I think a very strong message that primary HPV screening is superior to cytology alone, because I think there are still debates in various countries in Europe whether we have co-testing, whether we should stick to the thing we know, such as cytology. And that, I think, is important. Validated tests, very important, very interesting in the sense that the distinction between the mRNA, the aptamer test versus the DNA test. I mean, in the UK, the screening program is using an RNA test at the moment, but this is a clinician-taken sample. So self-testing is really the way forward to increase access, I think, and I'm really grateful that Marc mentioned it. Urine test, I assume, Marc, you can comment on this when we have a chance, is also a good way of testing men. A lot of my female patients want their men tested for, men partners tested for HPV. So we have a number of very important messages. We can now go to the questions, and we have a number of questions. We have our own as well, but let us look at the questions. So I don't know whether Kai, do you want to?
I can start. Yeah. Maybe I still use my privilege to to ask the first question myself from Professor Donders. So you should switch on, unmute yourself. So you were talking today, I guess, about women in, let's say, fertile age, adult women. What about the same question, vaginal discharge, what and when to treat and what to look for if a mother comes with a prepubertal girl, for example, a girl 9-10 years, or does your talk apply also to postmenopausal women? So could you please comment on these two age groups as well? Thank you.
Yes, thank you, Kai. Thank you again for the platform and the opportunity. It's great to have this discussion. The question you ask for prepubertal and menopausal women is almost alike. I mean, the problem they both have if they have a discharge is most likely that they lack estrogens. And in small kids, if they lack estrogens and they have some stools in the vagina because of improper cleaning themselves, and they come to an age where they don't want mama to help cleaning, and so they do this themselves, and then they wipe in a good direction, but they wipe 3-4 times and so on. I mean, there is different mistakes happening, and most likely these kids have a enterococci or a E. coli discharge. So don't treat them with antibiotics. Certainly don't treat them with antifungals, because that's what's been done all the time. And I've never seen a candida with a young kid of that age, at least not a healthy young kid. What they usually need is a little bit of Ustriol. So if you put this Ustriol cream and put it on the vulva smoothly, it will go a little bit inside, it will absorb a little bit, it will give a little bit estrogenization of the vagina, which produces lactobacilli, and they will heal themselves. In menopause, very often it's more diverse. They can have different things, even trichomonas. So you need a proper workout to see what causes a discharge in menopausal women. There you have the other problem, that is that a lot of doctors don't even do any exams. They think, oh, she is 55, so she must have shortage of estrogens, so we will start estrogens, and they will give estrogens in the vagina, they will let them put estrogens on their skin, they will let them swallow estrogens without even looking. If you don't look in the microscope, you don't see parabasal cells, you don't see any lack of lactobacilli. Why would you give these women estrogens? They may have enough. So it requires a proper workout of the symptoms in menopause. They can have BV, they can have tricho, they can have AV, they can have candida, they can have anything.
Thank you. I will take the first question from our list of questions, and then I will give you over, Ali. Yeah.
Okay. Okay.
Yeah. So the first question we have is as follows. Have you any experience of treating? This is to Professor Donders again. Have you any experience of treating Staphylococcus aureus colonization in the vagina? An asymptomatic patient with persistent carriage has a partner who gets a rash on his penis every time they have sex. Her examination is normal, no vaginitis, no leukocytes, normal lactobacilli. So actually, I would even ask a little bit broader, that in the case of BV also, or what do you think about how to approach the partners, or also oral sex, for example?
Well, I thank the author for this question. This is really the best question I could get because it gives you the example of what I meant when I said don't treat cultures. Okay, this is a perfect example of this. What most likely happens in your patient who causes irritation on the penis of her husband after sex, it's usually the day after. Most likely these patients have a occult carriage of Candida albicans. They don't have well, of course, in cultures you can find Staphylococcus aureus, and there is people that are colonized with E. coli or with enterococci or with staphylococci all the time. But the question is, if you receive a culture telling you this is a Staphylococcus aureus, will you treat with antibiotics or not? The answer is no. Please don't do that, because you will worsen the symptoms, and probably you have already tried it, so you know that I'm right, that it doesn't help. Most likely this is a misdiagnosis of something else. What you could do is let this patient self-sample herself with cultures every week when she has more symptoms, to see if there is a candida one day or another coming out of your cultures. What you could do is use a PCR to be more sensitive in your diagnosis, and you may find one of these candidas that are not culturable, that we don't know yet, and that needs treatment. Or what you could do, give her a treatment trial with an antifungal to see if the symptoms go better. Put her on the recidivir regimen, give her once a week fluconazole, and see what happens. If the symptoms go away in the husband, you know it was candida, it was not Staphylococcus aureus. So I think don't treat cultures if you don't have any symptoms that fit with what you find in the cultures.
Thank you. So I will give over to Ali.
Okay, thank you very much. So we have a number of questions. We also actually, I want to just deal with a couple of comments. So Mireille from Belgium, who is sort of co-president of our Congress, has left a message to say, she's left now, but she says she's going to promise that we will add chocolate and beer tasting to the Ghent Congress. So that is good. That's we now have it in writing. And I see that we have a message from Mary O'Flynn. Mary, good to have you on the webinar. Just sending a thank you for the topics in this webinar. And Mary, we'd like to see you and the Irish contingent in Ghent. The next question comes as such. Again, it's to Gilbert. So wants a clarification with discriminative inflammatory vaginitis diagnosed, she says, as AV, if it lasts over 6 months. I'm not very sure whether that makes sense to you, Gilbert, but it's again a question about AV.
Yeah, it's not 6 months, Ali, but it's the score of 6. If you have an AV score of 6 or more, it's called severe AV, and severe AV equals DIV, so discriminative inflammatory vaginitis. And that is what is the power of the AV diagnostics. You unravel the different components. You look at the inflammation, you look at the atrophy, you look at the infectious component separately, and only if all three of them in their maximal extent are present, it means there's lots of atrophy because there's lots of parabasal cells. There is no lactose, and there's lots of other bacteria like cocci, and there is a severe inflammatory response with lots of leukocyte. If you have all three of them together in a maximal extent, it gives you a high score of the AV scoring system, and that is exactly equally as was at what was described as DIV, or discriminative inflammatory vaginitis. So the answer is a full yes. If you have a mixture of all three components together, you can call this DIV. It's the same entity.
Okay, so we have a question which is related, as a matter of fact, from someone saying they work in primary care, and the question is, I mean, do we, when we are taking samples, for instance, what do we sort of ask the laboratory to do in relation to AV? What are we looking for in the report that comes back to us? This is a more practical question for a jobbing clinician, which who may not have a microscope. Yes.
Thank you for that. Again, it's a plea to don't think that a microscope is out of reach, because most people think it's difficult and it can't be done, and you know, unless you have no electricity, a microscope can be used, and it's easy to learn it. You come to one of these courses, we can teach you how to do microscopy. I mean, Kai was there, she knows. It's elegant, it's perfect, and everybody can learn this. So this is question number one, answer number one. Don't think it's not feasible. It's really doable, and we've done studies to show eloquently that microscopy can be learned in 10 hours time. So having said this, there is other options coming. And this is also an answer to another question that I saw in the list. There is bedside tests being developed for both BV and AV nowadays coming. And most of them are still based on enzymatic methods with sialidase, but there will be also tests coming based on PCR. So there will be PCR tests coming. There was already one developed in Moscow, in Russia. There is now another one tested in China, and that works. And finally, a Chinese group in Taijing Hospital, close to Beijing, a big city there, they have performed a lot of work in over 1,000 patients and have validated this test in 300 more patients to use the gram stain also as a substitute to wet mount. So then you could send a swab to the lab, they could do a gram stain, and now soon, if this paper gets published, we're working on this, the gram stain could also be substituting the wet mount to make the diagnosis of AV. Because as long as you don't have lab people looking at the host response, you will never be able to diagnose AV well. You need both parameters in the same diagnostic algorithm.
Okay, super. Thank you very much. A couple of questions for Marc. So there is a question which says, "What are? I mean, though you discussed it, what are the advantages of RNA tests over DNA tests? Is there an advantage?"
One advantage is that it has higher specificity compared to the validated DNA tests. So this means less screen positive, a lower burden of follow-up and treatment, an economical advantage. But a clear disadvantage of the RNA tests is that they are not sufficiently sensitive on self-samples. Also, the longitudinal evidence for equal performance with respect to sensitivity and safety is based on a quite low number of studies. So the evidence base is smaller than for DNA testing. Okay, another question, okay. Marc. Sorry, Kai, yes?
No, but let's ask.
Yeah, there's Marc. Another question about self-sampling. So the question, if I can sort of rephrase it, it is, what is your opinion when looking at self-sampling? Is it the answer for easier access, which I assume is yes, but how do you see self-sampling sort of being a game changer as far as cervical screening?
We have seen in many countries who have experience with invitations of women when they are due to the next pap smear, that the coverage does not increase any longer anymore over recent years. In several countries with well-organized screening, we see that the coverage is even decreasing, in particular among the younger generations. So there is a need to increase the coverage where it was high and where it is not so high anymore. And in countries where the coverage is low, we need better strategies. So one strategy which really has been demonstrated to be more performant than the conventional invitations to come to a doctor or to see the clinic where a medical professional takes a cervical smear is the offer of a self-sampler. We have, I did not show that because it was not in the title of my presentation. We have pulled evidence from randomized trials where the offer of a self-sampling device was compared to the response when the women receives a traditional invitation. And we see systematically, consistently, a higher response rate when the women receive the self-sampling device directly at their home address compared to a traditional invitation. When the woman has to do an effort, for instance, she must order the self-sampling device, or she must contact a doctor or go to the pharmacy to get the free self-sampling device, then we see that the advantage of offering self-sample largely disappears. Now, a remarkable finding, which comes from Belgium, is it was a small randomized trial done in the neighborhood of Brussels. And at a GP practice, a medical student had set up a trial. Women eligible for screening, who were not screened since more than 3 years ago, were randomized in A and B. In A, they received a self-sample directly from the doctor with the necessary explanations. In arm B, this was the comparator arm, they received just a recommendation to have a pap smear taken by a doctor of their choice. In arm A, the response was 78%. So in our randomized trials, population trials, in the self-sampling arm, we had on average 20% participation. So this would be in particular an option to reach more women, is to include GPs in reaching women that do not participate in general who do not have a gynecologist. There, the gain in participation it could be huge, but this should be repeated. And now we have trials that have been submitted for funding, and we hope that this will be accepted in Belgium, but also in a few other European countries.
Excellent, thank you very much. Over to you, Kai.
Yeah, the next question is to Gilbert again. So it goes as follows: asymptomatic woman with positive PV on pap smear. How do you manage? What would you do if?
Unmute yourself.
Unmute,
you're muted, Gilbert. Unmute.
Yeah.
Sorry, I had a phone call, so I switched it off. Very good question, because it's very frequent that you get a pap smear back with these type of results. For me, the answer is simple. As I said in one of my slides, treat symptomatic patients. Don't treat results. Don't treat cultures. Don't treat pap smears if they're not show you what you're looking for. A pap smear is made to diagnose precancerous lesions of the cervix. It's not made to do diagnostic work out of the vagina. If they do find it, it all depends on the symptoms your patient had when you took it. If you took a pap smear and you didn't have any smell, and the patient didn't complain of any smell, or if you have the smell and you ask the patient, does it disturb you? Did you smell it yourself? Does your partner smell it? And they all keep on saying no. Why would you treat that patient? I mean, I would never do so.
Thank you. And one more, what medication do you recommend in order to decrease pH in case of Candida?
Well, the pH question that needs treatment was rather meant in the entity of cytolytic vaginosis, not so much in Candida. If I have a Candida, I give antifungals. And there was no questions about this, but at the end of my lecture, and maybe it was a bit long. I'm sorry, Ali, that it was a bit long. But the end, I showed very promising antifungal developments, which are so huge, and it's coming towards us. And so we will have a game changer with these new products. So for Candida, to make a long story short, we still need anti-Candida drugs. I mean, there is no way to take Candida away by acidifying or lowering the acidity of the vagina. For cytolytic vaginosis with symptomatic patients with burning, it does. It gives them a very big relief if you lower the acidification. What I usually do, because there is no products on the market yet for that, I give them sodium bicarbonate, which is a baking soda powder. And I let them fetch 12 grams at the pharmacist, and I let them dissolve it in 250 milliliters of water that they can use to rinse the vagina in the end of the evening. And when they go to sleep with this, they can find how many times a week they need to do that in order to keep out of problems. And most of these patients, they use it once or twice a week and are fine with this. So this is, for now, the best treatment we have. We, in Portugal, with the Covilhã University, I'm having a PhD student who's working now on a cream that we could use to have the same effect, but we're still working on that.
Thank you. So Ali, your
Okay, so the next question is a question about the vaginal microbiome. So it's asking, what is the origin of the vaginal microbiome? Is there an effect of the microbiota of, for instance, of the gut microbiota on vaginal microbiome? So because you talked about using probiotics vaginally, but obviously if the bowel has an effect, the gut has an effect, you may need to take something orally. So can you comment on the gut microbiome in relation to the vagina?
You have another hour?
Well, maybe we'll invite you next year again, or maybe yes, we can talk in the Congress about it.
Yes, we should, because the vaginal microbiome is now a very highly studied entity, and I think that the question is well taken, and I thank the author for this, because it's of course so that there is a relation between bowel and the vagina. Everybody knows this. I mean, the proximity of the two openings is so small that it can't be otherwise. And we do know that there is an influence. We also know that a baby that's born, from the very first days on, there will be a adaptation of its vaginal flora, which is linked to the bowel flora, which is linked to the skin, and mostly the skin and the bowel of the maternal flora. There is even groups that say you should wash these babies with some diluted E. coli from the stools of the mother if they're born with C-section and all these things. Nowadays, we no longer endorse this. There is no reason to do so, but just telling you that there is definitely a relationship. Having said this, if this means if you give oral probiotics that you influence the vagina strongly enough to cure a bacterial vaginosis or a AV in that vagina, I'm not sure. I don't know how many kilograms of probiotics you have to swallow in order to make such a dramatic change so far away from the mouth. So it has to travel all these meters of bowel and then get out and then be present there in high enough quantity to colonize the vagina in a sufficient way to make a difference. We don't know yet. I mean, there's a lot of research going on, and the answer is still out there. So that's why I prefer vaginal direct applications of probiotics in cases of diseases or prevention of recurrences.
Okay, Kai?
So this is, we are almost, I think time is running, so we can maybe take one or two questions. So this is maybe for both our presenters: dysbiosis and risk for cervical sensitivity concerning HPV infection. Is there any rationale?
Marc,
So,
can I start?
Yeah.
Yes, there is. Most studies show the answer is the lactobacilli. There is good evidence now that lactobacilli can decrease the inflammation. They decrease interleukin-6, for instance, in the vagina, and they have a anti-viral property. So in a healthy vaginal flora with good lactobacilli, especially Lactobacillus crispatus, not with Lactobacillus iners, because it has not that ability. Because in Lactobacillus iners, indeed, there is more dysplasia, but it depends on which Lactobacillus you use or you have on board, and which properties it has influences the chance that HPV can cause dysplasia of the cervix. So the answer of this is not the anaerobic bacteria so much, it's more the absence or presence of a powerful lactobacilli.
Thank you. And Marc, do you have any additional comments?
The HPV test is sensitive, and in many circumstances, women with without infections, there are a predictor. So it might be true what Gilbert is saying. I do not have evidence on that. I look at systematic reviews when I must answer such a question. I cannot refer to expert opinion. And the expert here today is Gilbert, of course. I'm an epidemiologist. So,
I'm referring to a few studies, but I don't know if there's enough studies to do a meta-analysis, which is your topic. But there is a few studies that I was not involved with, but they showed this evidence. I'm not inventing this.
Yeah. Okay.
Thank you.
Okay.
Show me them, Gilbert.
Thank you. So, Ali, one more question or
yes,
concluding
I think we
already?
will. I think we had such an interesting afternoon, so I'm going to see if we have any more interesting questions and try to put them to the speakers.
Mr. Chairman, if I may, there was one of oral sex. Maybe that's that's a quick one. We can do something
Okay,
about.
okay, you do that.
Yeah.
That I raised that, I think, but yes, go on.
Me too. So
Yeah.
this is always a question.
Well, I think I'm glad you raised this, because when you have sex, most of people nowadays have very liberal ways of having sex. It's not just penile, vaginal penetration, of course. There is lesbian sex, there is homo sex, all different kinds, and oral sex is definitely very frequent. It's good that you raised that question, that if there is a risk for sexual transmitted infection, it's not only by regular penile vaginal sex. Also oral sex, also anal sex have a risk of transmitting these diseases. And there is definitely chlamydia in the throat, there's gonorrhea in the throat. There is also transmission by this way. So yes, you have to be aware that if you are afraid of sexual transmitted infections, oral sex is a thing to look at. If it transmits BV, I don't know. I do know that lesbian women have more BV than hetero women, but it's not clear how that comes.
But there are patients, at least in my practice now and then, coming that they have noticed that every time after oral sex, the BV is back. So it's quite common empirically.
Yeah, I mean, I think this is not for this platform, but I think discussion of sort of sexual practices are very important. So oral sex can be different things. A tongue in the vagina is different from other. You need to really just think about that, and also in relation to HPV. I raised it, and Marc, I don't think made a comment. There is a question, Marc, which says, would urine testing be the optimal test for men?
In clinical practice, it might be useful to test men. We do not have any evidence that screening for HPV among men protects against penile cancer or other cancers. There is some evidence for screening in anal cancer, but only for high-risk groups. Yeah. So HIV positives, MSMs could be a target group for anal cancer screening. But we have so hard evidence that screening protects against cancer among women. For men, we do not have such evidence to make it as a population-based screening. But in clinical practice, yes, HPV testing can be done in men in several ways. There is no optimal methods. There are several methods, several anatomical locations. For urine testing, we have now growing evidence. We are doing research ourselves. And again, under the condition to use a good validated PCR, already validated on cervical specimens, probably urine could be as good as a cervical specimen, but it's too early. We just have information for a few tests and a few urine devices to come up with general recommendations. But what we know is that women, they prefer urine sampling more than vaginal cell sampling. For men, we do not have data about their preferences, penile collection or urine collection, and we do not have data on the accuracy of urine collection for HPV testing in men. Okay, thanks very much. We are over time. I'm going to take one more question, and then there are some late ones. So we have one from Professor Siso, which we will try to answer later. We've got a number of new ones which have come out. But I want to there's a question which is not necessarily about vaginal discharge, but Marina Tocci was asking pain with herpes vaginalis. So with herpetic infection, is there any distinction?
is there anything we need to sort of say in the differential diagnosis, I guess? And this is the last question.
I guess that's one for me. Once more, I think we should talk more about infections, but you see there's a lot of unanswered questions concerning herpes. The difficulty, of course, is that along the way, herpes gets chronic. It's hidden in the nervous system of the pelvis, and has outbreaks at different times, which you can't predict. And that's the difficult thing. In some women, there is a prediction that is linked to the menstrual cycle, but in most women, it's not like this. So this makes it difficult to manage genital herpes. We have now a similar regimen that we use for BV and for Candida that says if you have 4 or more relapses on a year, you can call this a chronic recurrent condition. And then we consider these diseases as chronic diseases which require maintenance treatment. So we no longer give episodic treatment, but we move to maintenance therapy. And also for genital herpes, you can do that. So you give then 2 times 400 milligrams of acyclovir, or you give valacyclovir 2 times 250 for a prolonged period of time. And how long you should prolong that period of time depends on your patients. You can let them stop after a year to see if it comes back. And if it comes back, you can continue it even for many years. So that's basically the only new item. There is people trying to find a vaccine for genital herpes, recurrent genital herpes, but recently I didn't get any more new information on the phases that they are in now.
Okay, well, thank you very much. We'll answer the few more questions that we had, hopefully, in writing. So if you have access to our website and to Doc Matters, they will be in Doc Matters, you will find the answer. Can I just thank, first of all, Kai for guiding us through the webinar. Thank both Professor Donders and Professor Arbyn for their fantastic presentations, and the many questions and appreciations are all there. This is our last webinar for this year, so can I wish you happy holidays when the holidays come. Enjoy Christmas. Use the time in Christmas to register for the Ghent Congress. That's the best thing you can do on Christmas Day. Maybe consider it as a present from one partner to another, so that we can see you in Ghent. And hopefully we will meet you in our first webinar in 2022, which will hopefully be in January. So thank you very much, and thank you for Peter for also just looking after us in the background. And enjoy the rest of your evening.
Thank you.
Bye-bye.
Bye.
Bye.